Hello and welcome to episode 17 of Listen Up podcast, brought to you from Abacare Recovery. Today we've got Allan Houston as our guest. Allan is a senior addiction worker at Glasgow ADRS. Also, he's a co-lead at Humanizing Healthcare, and Allan has also got lived experience of addiction in over 3 decades of recovery. Welcome to the show, Allan.
Thanks, Eddie. Thanks for inviting me.
You're welcome. Good to see you. Okay, Allan, so what's been the most significant changes within your working role with people in addiction in Glasgow over the years?
I've worked in addictions for a couple of decades now. I've worked in Northwest for 18 years, but before that I worked in the homeless addiction team, which used to work with the most chaotic drug users. And I suppose lots of changes have happened over the years. We used to run clinics, methadone clinics mostly, because that's what we had to as an opiate substitute treatment. But now we've got Buvidal, Espinor, various aspects of treatment. It's not just that one drug that we gave to people. So significantly for me over the years, the loss of the methadone clinics has been massive, because if I had ran a methadone clinic, then if 20 people booked in and 3 of them never turned up, I don't really need to worry about those 3 people. But now we put prescriptions into chemists for 2 months at a time. And sometimes the groups that we work with are pretty chaotic, and sometimes I could spend the full week dealing with 5 people.
Yeah.
And I don't get round to seeing the other 30 people that are on my caseload. And then it comes round to prescriptions again, and then we get a chance to maybe phone them, catch up with them. But significantly over the years, then there's been massive changes in addiction as well. But that's probably the most significant ones for me as well.
So you're speaking there, Allan, about the kind of bigger changes as the kind of medication being offered to people with opiate addiction. What are we seeing in Glasgow just now, or Scotland, as far as you know, regarding the drugs that are causing the biggest harms?
Well, the synthetic drugs that are coming on scenes, nitazines, the fentanyl that's been mixed in with some substances as well. We don't know what. I remember dealing with a case where somebody had been taking street Valium and there was Rohypnol in them, which is a date rate drug. So this girl had spent 3 days under the influence of these street Valium, not knowing what was happened. Still could not recall when I met her what had happened. And the potential for lots of young people taking recreational cocaine use at the weekends, and nitazines find its way into these sources. And I think in England there was about 35 deaths through people taking recreational cocaine use at the weekends and dying. So there's been massive changes. And lots of times people come into our services, then they're not just using one drug, they're using cocaine, alcohol, various things like that. Less so heroin, but still there's a lot of opiate use in Glasgow. And obviously with the drug deaths increasing repeatedly over the years, getting higher this year again, then it's pretty worrying, because I think that we find it difficult to get it at its source, and it's so easy to mix drugs. But yeah, it's a bit of Russian roulette out there, I think.
Yeah. And it seems to be the case, seem to be hearing about kind of more people dying, but not with your kind of standard what we used to, heroin overdoses or benzo overdoses or whatever. What do you see is getting put in place from a kind of harm reduction kind of aspect of things regarding kind of combating things like nitazines and fentanyl and stuff like that, or is that out of control?
I think it's a massive task to actually find them and controlling it. If somebody's really want to get a drug out there, then they'll get it out there. Whether it's police are probably powerless to control this. I think a few years ago they were trying to control the presses coming into the country as well, but I don't know how they got on with that. but they're trying to, the pill presses for people making Valium, street Valium every day, the harm reduction model as well, we are getting better at actually giving out harm reduction in the sense of tinfoils. If you mention tinfoil to somebody, they're saying, what's that about? And it's about maybe people smoking drugs, and it's a bit safer because there's no damage in the throat because the toxins will be taken out of the tinfoil. Needle exchanges, the drug deaths, the rise in naloxone. One of the things as well that's been pretty positive as well, that the police now carry naloxone. Whereas I remember a story years ago where one of the community was standing in the street and somebody had overdosed and they were trying to intervene with a naloxone kit, which had the needle on it. And the police stopped them from giving somebody a naloxone injection because of their lack of knowledge. And then they actually told them not to get near the body, which I understand because they're getting close to somebody who's unconscious in the street. They've got a needle in the hand and they're going to give them this injection. The police were no-go. But the police over the years have became a bit more involved in the community. They now carry the nasal spray of naloxone as well, which is probably a great harm reduction. And there was reports that they'd used it quite a lot. And in Glasgow and Scotland, then I'm sure that it's badly needed. Because the amount of people that are overdosing because they don't know what sort of drugs they're taking. They're talking about drug testing coming on board as well. I don't know about anybody else, but I would be reluctant to give my drugs up for any testing. Hopefully people will. But when I was using, then if I had a pure batch of heroin, I would be delighted. I'd probably raise my prices. But it's about education, people making informed choices whether they still want to take that drug once it's actually been tested. And they're talking about getting testing kits in certain areas. They're talking about the city centre, where I think that we need more harm reduction things in the communities. We've a drug consumption room in one centre point. Nobody, I work in Postle Park in Northwest to Glasgow, Drumchapel, various things like that. Nobody from those services or from those areas is going to travel into Glasgow when they've got something to inject. They'd rather do it in their own communities, and they're sometimes dying in their own accommodation on their own without anybody around about them. So we try and encourage people not to use alone, to carry naloxone, family members to have naloxone. So there's lots of steps forward about harm reduction information's out there, but still people are dying.
Yeah. And obviously over the years, you know, Scotland's had a very different relationship with substance use for neighbouring countries, even England and stuff like that. What do you think's different about people here in Scotland regarding their drug use and maybe the underlying issues of that?
I thought about that quite a lot, and we've probably discussed it a few times. It feels as if Scotland have this relationship with downers as well, that a lot of people in Scotland seem to want to get into. Even years ago, I think lots of people, when I was using, and I get clean in 1993, but I remember there was a period at that time where people were getting into ecstasy and going to raves. But I was probably at the end of my using at that time, and it was £20 for an ecstasy at that time, right?
Yeah.
There was no way I was buying an ecstasy tablet with £20 when I could have bought a £20 bag of heroin at that time, right? Because that was my drug of choice, because I liked downer. But I've been through the periods of uppers, various things like that, and then I started taking downers to come down. So I think that the whole aspect of that Scotland have really got this, it's like a depression sometimes, as if there's a real depression, and we want to cover that up with some substances like heroin. Like that time it was temazepams, which was known as jellies at the time, and then moved on to temazepam. But I remember taking amphetamines. It's not about drugs, but I remember taking amphetamines, telling everybody I'm clean at that time, because I was using Temgesics, Pink, Speed, and jellies, but I wasn't using heroin. So in my eyes, I was actually clean. And it was the speed at that time. It was the most depressive, isolated time of my life. and it was supposed to be an upper.
Yeah.
I didn't enjoy it. I wasn't eating right. I wasn't sleeping right. So my health had deteriorated rapidly. But I had this period that I was trying to stay away from other substances. And all I was doing was just switching one drug to another.
Yeah. So on that kind of theme as well, what significant changes have you seen recently since Scotland's attempted to make all these kind of changes to support people with addiction issues better? What are we seeing in Glasgow and what we seen nationwide? What are significant changes to try and combat these drug deaths, other than the harm reduction kind of side of it?
Yep. I suppose the whole aspect of even the drug death task force was set up because we understand that we had to change the narrative on the criminal justice into a public health emergency, and the public health emergency, then the MAT standards. I was actually involved in the drug death task force for a couple of years, and the MAT standards was one of the subgroups that I was involved in, running about people. And I'd said at the time that I was sick of getting into work on the Monday after getting Facebook requests, which I had to completely ignore because of boundaries.
Okay.
But people getting released from prison on a Friday afternoon and then reaching out and saying, Alan, I went and used, but can you get my script today? Because I went and used, I have to come out there, but I really went back on it. And sometimes by Monday it was too late.
Yeah.
Unfortunately. Sorry, just say that wee bit of the question again.
Yeah, so what have we as a kind of nation fallen on for year after year, having like the kind of worst rates of drug deaths in Europe? What significant changes other than the kind of harm reduction kind of approaches we discussed earlier?
Yep.
What would you say is significantly changed, and what is Scottish Government's main kind of approach to combat the drug deaths?
Yeah. The MAT standards would be using work, which is great because what time is it just now? So it's 10 to 11. So I could go up to our offices just now with heroin problem and discuss with a worker immediately. And I could probably come out with a opiate replacement treatment before 12 o'clock after seeing a doctor, seeing a worker. And if that took away the chaos in my life, great. Then we open from 8:45 in the morning and up to about 4:30, you can come up and get that service Monday to Friday, every day of the week. Maybe a wee bit more aspect would be around about some weekend stuff. But the MAT standards, trying to get with full staff team psychologically informed to trauma informed, which is a work in progress. The psychosocial interventions, we've got the growth of recovery communities over the last 12 years in Glasgow, which is massive, which I was delighted to be part of for a number of years because it gave me an aspect. I came for chaos in my lifestyle, and then getting into recovery, and after coming out of that, growing up in chaos, using in chaos, and then coming into recovery and starting to drink green tea and spiritual principles and all those things that come along and changing your life completely. So for me, then there has been massive changes in soft touch relationships around about. I did a men's group on mindfulness for about 11 years in Glasgow. And it wasn't about the mindfulness. The fact is, you get sometimes 45 men come to a centre in White Inch, and what would happen in the room was we'd get something to eat before it. There was connection. People who'd maybe isolated or a bit scared to come along. So we get outreach workers to bring them along and just provide that sort of support. And what happened in the meetings was that people would say, what are you doing after this? I'm going to a fellowship meeting. What's that? Can I come? And all those soft touch interventions happened all the time. And people would then go to meetings, then you see them come back next week and they'd stay for the meeting after it. They'd go to another meeting and they'd interact with other people when some of the times people would have been isolated for years.
Yeah. So say I'm somebody living in Glasgow at the moment. I've identified I've got addiction issue. I find out about the kind of MAT standards and go to a service like yourselves, and I get put on a substitute medication, which kind of, as you said there, gives a bit of kind of stability into my life, takes away the chaos of drug use and drug dealers and whatever else, crime, whatever else comes along with that. What kind of follow-up support would I receive, or would I be advised to do? What would I be provided with other than the medication?
Good question. Hopefully, the connection with a worker, hopefully you'd be able to become a wee bit more honest as the chaos left your life, that getting a worker that you can trust, that you can then access some of the services. I think that in our team, then there should be a longer induction period so that staff know what's in the communities, so you can signpost people to the most relevant services. Fortunately, I worked in this line of work for that many years, and we have a thing in Northwest as well where they do the recovery-oriented system of care, where they try and the Northwest recovery communities have this every 6 weeks, and they try and bring all these services into the one room so that they can give that information out. So staff are encouraged to attend these services, these groups, so they can then have that information to give to the people they're working with. Because if you get in and you're just getting a prescription and it's getting put in a chemist, then there's nothing going to change too much. So that relationship that you have with somebody, maybe even phone them up, trying to get me a wee bit accountable to keep in contact with you every week. And the whole thing about the MAT stand as well is it's supposed to be your informed choice. Hopefully it's changing, but I've seen myself beginning with 2 prescriptions. One's Eddie's wanting to increase today, Eddie's wanting to reduce. I should be treating the 2 of them the exact same way, right?
Yeah.
But sometimes medically, then it's said, oh, you need to get some more information if you want to reduce.
Okay.
Because we don't really want to reduce that just now until we get all the other things in place. Whereas if it's an increase, it's usually signed right away.
Yeah.
Which I should have been in the exact same conversation with you. Why do you want to increase, Eddie? What's going on?
Yeah.
Where do you want to be in 6 months' time, Eddie? Where do you want to access? What sort of things do you think you need? Is there any bereavement stuff? If I've got a relationship with you, I'll know a wee bit about your past. Is there anything you need to access counselling-wise? Do we need to refer you to psychological services, which we have in our team? Is there any occupational health issues? Harm reduction information? If you're still using Topidas prescription, then fine. We're not going to judge you, but do you want to continue doing that, or are you hoping to reduce that? And I think keeping that question live when somebody comes in to see you all the time, where do you want to be in the next few months? And it talks about in the MAT standards that the informed choice should come from you as a service user. And sometimes that's no falling through to every worker. So
that's what I was going to follow up there. That sounds like a massive demand on services, that everybody has that right for the MAT standards to turn up, get put on a prescription at that time, then get the adequate support and signposted. Have we seen this across Scotland being implied, and what kind of pressure is that putting on services like yourself?
This is my personal view, in the sense of that Scotland-wide, we cannot provide the exact same service. If you go to Glasgow, we're very rich in resources in Glasgow, which is great. But even going further afield, then you're not getting the exact same service in rural communities because they don't have the doctors to same day prescribe. So they don't have the staff to follow up with all the other stuff that you may need. And sometimes that might just be that you get a prescription from a GP. We have the shared care staff as well in Glasgow, which they work closely with the doctors to provide that support. GP link workers when you go to a surgery as well. And we have something in Glasgow as well, which we introduced during COVID, was the RAG system, which is red, amber, green. So when somebody comes in being assessed, then in your mind you're thinking, are you a red? That chaotic, I need to keep contact with you every week. No, you're a bit of an amber, which might sound a bit crazy in the sense of I'd be treating everybody equally, but if I've got less chaos in somebody's life, you can maybe refer them on to other services like With You, who follow up with the greens. We're at a stage. We have a STARS team as well, which is supporting treatment outcomes. So if somebody's stable, we'll refer them into STARS in our team as well. But it means that the workers are probably getting burnt out with working with reds and ambers all the time, because it's constant chaos. As I said before, I was involved in the Northwest recovery community for about 10 years, and I got to see the other side of the chaos where people get in recovery, get along, connect with somebody, shakes hands, sit down, get a cup of tea and a drop in, and then they go into meetings, fellowship. The fellowships in Scotland or worldwide are massive. Do you know what I mean? There's millions of people go to fellowships, but we're still reluctant for staff to take people along sometimes. Hopefully, even in the signed guidelines, it talks about people should be taking people to meetings, getting fairs to take them along to meetings. But when you ask a full staff team, then there's very few people at certain levels will go to these meetings because they don't really understand it and they've got their own views and opinions. So please go along to open meetings. Mm-hmm. If you're looking at any of the fellowship stuff, there'll be an O next to in the literature, it will say open, which means that you can go along to any meeting and find out what people are going to experience. Otherwise, you'll be sitting in front of somebody telling you all the negative aspects. It didn't work for me. They were selling drugs there. Yeah. People were trying to get into a relationship with me. That happens in a small minority. Do you know what I mean? The fellowships are massive worldwide for a reason, because recovery works. Recovery is possible for everybody. And the opposite side of that is there's not much profit in recovery.
Yeah.
Do you know what I mean? Mm-hmm. So keeping people on medication, pharmacies, the amount of money involved in that is massive.
Yeah.
And that's not being cynical.
No. So that kind of take us on. So you're somebody obviously with lived experience of addiction yourself, Allan, and you're over 33 years in recovery of abstinence-based.
33 years this month, yeah.
Abstinence-based recovery, which is absolutely amazing achievement, and it's an amazing example to people kind of listening or within the recovery communities to see that that's achievable. What was your kind of pathway into recovery? What did that look like?
I can't tell you that. I used for a very young age. I grew up in a household where drugs and drink was probably rife, and when drugs came along, it was a bit of relief, to be honest. And I used for years until I was about 25, which I got recovery pretty young. And I remember getting told that I needed to get help. I never really sought help. And I went to a place called Robert House, which is no longer there. And in Robert House in 1993, I was the last resident. And I went in there thinking, well, I'll get in here, get away from that, keep social work away from my door, keep the police away from my door, and maybe be able to address some of the issues in my life. Mm-hmm. And I'd had lots of attempts, locked myself in house, getting into prison, coming out and not knowing how to cope. And I didn't know that I didn't know how to cope. Mm-hmm. But I just came out and I just used because that gave me some sort of comfort. And I remember getting into this place in 1993 with no really idea of what was going to happen. And I went in there and I remember the first day they took me down to Byres Road in this Robert House, and I was bouncing into poles because I took drugs in with me. And the staff were all actually work beside some of the staff now in the same role. But the staff pulled me aside and said, look, what have you brought in? Nothing. Lied, right? And they gave me a chance, and I did stay. And I stayed in there for 6 weeks, and then I was going to a rehab across the road in Great Western Road at the time called Rainbow House. And I still had a parcel of drugs. I just took the hydrocodone Valium in because that's the detox gave me so that it couldn't show my urine. Okay. And I went in there, and after the 6 weeks, they took me out because I was last resident. They were closing the building down, and they bought me my last 2 pints in June the 22nd, 1993, down the Ashoka Lane. And they told us, we're taking you out for a meal. They're probably getting ready funds for social work. Yeah. So social work bought me my last 2 pints, right? Which is great. Now I work for the social work. So went in there and then went to rehab. And I'd been to the Prince's Trust for an assessment, and I was ready to join it. And went in there to rehab for 4 days. We still with a parcel, which I hadn't used that night. And I went to an NA meeting. And with a guy who was in there, Kenny Slavin, who had encouraged me to go to a meeting. And he was actually sharing me. I didn't know he was sharing me, but he was trying to get me to identify. He was talking about his ex-partner and his child, which was the exact same situation as myself. And I thought, Right, okay, I got along. And I went to a meeting. And after 4 days, then I'm down the stair and I said to the woman, "I've joined this Prince." "No, you're not. You're not joining this Prince's Trust course." Maggie Diamond it was. And she said, "You're not joining it." I said, I'm leaving. And I left after 4 days and thinking everybody was going to say, "Oh, don't leave, Alan. You don't know what's out there." And people were saying, "Can I get your toothpaste, big man?" So I left and I've been clean on that resent for the last 33 years, do you know what I mean? But I went to meetings. I went to a meeting that night and I've been to meetings ever since. I'm still involved in a group because it's no... And initially it was terrifying. I didn't know if I was going to stay clean, and I have. And that's through just going to meetings, getting involved in fellowship. And the fellowship at that time that I get involved in was very, very small, to the point where there was the same people there all the time. There was about 4 or 5 meetings a week. And now it's grown into about 70, 80 meetings a week. So just that growth, because people kept opening up our meetings, getting involved in me. And I've never really looked back. Have I had difficulties in that time? Lots. Did I struggle to stay clean? Yep. But it made it a lot easier finding other people who had been through a similar experience and told me it was okay. And I would never been able to talk about stuff until I got somebody that I could trust sponsorship. I was so mistrustful. The fact is that I always talk about this. People, when I first went to meetings, would say to me, "What's your name?" Because I used to talk into my chest.
Yeah.
Couldn't understand me. And I'd smile like that. "How are you?" "I'm fine." "How are you?" "I'm fine, mate." And they'd hug me and I'd be rigid. And over the years, that sort of loosened up and get a lot easier to deal with. And my head started to come up, my eyes started to sparkle a wee bit, and I get a bit of hope. And that took a few months to get that hope. After the initial thing of, I'm where I'm supposed to be. I can relate to that guy there. In fact, I know him from my scheme, and I use worse than him. If he can do it, I can do it. And that's all I had.
Yeah.
And over the years, then it's just become a lot easier because I'm terrified still to get back to that sort of way of life. That's why I still do it.
Yeah. You're just making me think there, Alan, you know, something I've been discussing quite a bit with people recently regarding how life just now for everybody is designed for comfort, isn't it? Everything's only a kind of finger touch away in a screen, or your car, your job, money, food, everything is just there set up for everybody. And getting into recovery is really difficult, isn't it? It's going to be challenging. It's going to be uncomfortable. Do you believe the way society is just now is making it difficult for people to make those changes? Because when you're speaking there back in 1993, it's a very different experience getting into recovery. Probably less services, and like you were speaking about earlier, the kind of harm reduction where you get provided with tinfoil, you'll get appointments, you'll get, you know, you'll get looked after nowadays with services. But back then, I would guess that was a very different
Yeah,
experience.
big time.
Mm.
I remember when you were talking there, I was thinking about, remember being in the jail, and I didn't understand the whole system at that time. I think it was my first time in. And I remember being in the police cells before it, and I'm, "Turnkey, get me a doctor, I need a doctor. Turnkey, get me a doctor." And he just opened the door, or a wee slot, and said to us, "Get your head down. Nobody's died for being strung out. Get yourself to bed," right? And slammed. Services have completely changed. You know what I mean? I would be mollycoddled probably in a sense in my eyes. And the whole idea of getting a sponsor at that time as well. I remember asking a guy to sponsor me when I first went, and I used to have to go into the phone box at the bottom of Pollock, right? I stayed in Pollock at the time. I remember having to walk away down to the bottom of Brockburn Road and get the telephone box. And I get to the digits and think, "No, I don't want to phone him." But there was no luxury of, probably people did have these big phones, right? Or people had Motorola phones, but I never had the phone. So even just that aspect has changed. Do you know what I mean? That everything's so easily accessible. You can go online, you can get into meetings online as well. There's millions of Zoom meetings online for fellowships, recovery groups. You would think that it would be easier for people to get into recovery. And the fellowships are growing massively. So hopefully people find it easier to access that stuff now. But I suppose the desperation at that time kept me going. I got a bit of hope through seeing other people, and I'd turn up when I said I'd arranged the day before, because you never had any phones at that time to keep in contact with people, which sounds a bit ancient, doesn't it? There probably was phones. I probably couldn't afford one at the time when I was first getting off everything.
Out of all your experience and years of experience in recovery, what do you feel is the basics that people need to achieve and maintain recovery? And I'm speaking there about kind of abstinence-based recovery. What's the basic needs?
That initial hope, even that judgment that if he can do it, then I can do it. I used worse than him. But even just finding somebody that I knew had lived that similar life and getting that hope from other people. I'd been to doctors and various things like that. And I remember one doctor saying to us, I wonder how you feel. And it was like, no, you don't.
Yeah.
No, you don't. Have you ever laid with your back crawling? Mate, that defiant way. And I remember going to a meeting and not being able to talk, but listening and thinking, if he can do it, maybe I can do it. Maybe he can just hold on. They're telling you to do it for a day at a time. Even just a wee experience. I remember a guy saying to us, and I always get called Houston, right? And the guy saying to us, walking up the road room, and I'm talking, nervous talk, because you're just off everything, you don't know how to communicate, you've been isolated for years. And I remember saying to us, Houston, if you're talking and I'm talking, nobody's listening, mate. Why don't you talk for 5 minutes and I'll listen? See those valuable lessons?
Yeah.
And like, if I'm arranging to meet you, I'll wait 10 minutes. If you're not here, I'm off.
Yeah.
Just all these wee lessons. And even people teach me how to be a better dad.
Is it
Insane.
It comes down to accountability, doesn't it? Which seems to be lacking in a lot of cases. And I believe there's a thin line between where maybe a lot of kind of places are doing the work for the people, rather than allowing them to do the work. And for people, as you know, and I know, people with addiction issues, when we're at that stage and stuff, we'll let people do that all day long, and do the work for us.
Accountability is massive.
Yeah.
Accountability is massive, and that empowering people.
Yeah.
Like, that's probably why I think that you can pick good workers and workers who maybe don't get that. The fact is that you can walk alongside somebody and encourage them. Maybe even the work in the Prince's Trust, I used to say to people, you want to make I'm really terrified to make that phone call and I don't know how to do it. Right, okay. Well, why don't I sit with you and we'll do it together initially? But then I want you to practice doing that yourself and just encouraging people and empowering people. Because people did that for me. They wouldn't mollycoddle me, and sometimes they'd be brutally honest, which I respected. I still do actually respect that. But you're right. It's so easily access services that we have so many rights as humans, which is great.
Yeah.
But do we take advantage of that sometimes still? Because we know we get into service, I know my rights, I'm going to fight this, rather than actually trying to have a relationship with the worker, because not everybody's out to get you. But having the airfield as well, then I remember meeting 5 guys. I had a group down at the Christ Centre, and I remember I had a wee group there on a Friday night, and I met 5 people that I knew, and I was saying to them, why don't you come? They were in getting needles, and I was saying to them, why don't you come up to our service and get some OST? And he said, Allan, I don't want to come up there because I know what will happen. So they have a preconceived idea of what will happen to our services.
Okay.
And they felt disempowered because they come along there, they get put on a certain amount of methadone at that time, and then they'd be increased, and they didn't really feel as if they had much choice, and they knew that that's not what they wanted. They'd rather use the heroin and then come off of that themselves. So it was a shining the light on how people were voting with their feet not to access our services because they had this idea. So I think that our services have got better at doing a PR job over the years to let people know this is what we can provide. We can provide same-day prescribing. We can prescribe access to psychological services. There might be a bit of a time limit on it. We can get access to residential rehab through our commissioned services, and also the Excel funding that's been set up by the Scottish Government to provide funding for other places. So there's lots of changes, and people know a wee bit more how to access that for the better. And there's advocacy workers who'll walk alongside you. I don't remember ever having that option of somebody will walk beside you and support you. Would that have taken away from... I remember my drugs worker in 1993 never came up to see me, right? And at first I was thinking, oh, this guy's not interested in... And do you know what it did? It made me make the phone calls myself.
Yeah.
It made me actually access the stuff in the community myself. And it made me take a bit of responsibility. And it talks about in the fellowship this just how much sooner become acceptable, responsible members of society. It is you take that personal responsibility. Because I spent my whole life blaming everybody else.
Yeah.
And that's what taught me in the fellowship. I had to get rid of all that blame. If I hadn't grown up in that childhood, poor me. If I hadn't grown up in that childhood, if I hadn't stayed in this scheme, I wouldn't have used. So what people were saying to me, but you're not doing it anymore. You're not living in that environment anymore. What are you going to do for your own recovery, Alan? And I suppose it makes you feel a bit more responsible for your own recovery. And still, to this day, then I have lots. I had my stag party the other night and there was about 27 people there. Do you know what I mean? I'm getting married this year. And I've got friends in that group who I've been friends with since I came here. So that's probably massively important to me as well, that I'm accountable to them.
Yeah. Oh, brilliant. In 2020, yourself and Hugo Jobs started an amazing project called Humanizing Healthcare. Can you tell us a wee bit about how this came about and what that is?
So, the amazing Hugo Jobs, who's now Dr. Hugo Jobs, started as a student, and he was up in Dundee, and his friend was in a drug problem in London, and he told him he'd been going to meetings in London. So Hugo went to the D fellowship meetings and loved it. He's not a person with lived experience himself, but he loved it. And he was coming to Glasgow after being in St Andrews, and he was coming to Glasgow to continue studying to be a doctor. And he got in contact with me and said to us, "Get this idea that I would like to introduce the recovery community's lived experience people to the medical students, because we don't get much training on addiction and various things like that. And I've been to meetings and I've found it so useful." And I said, "Right, let's meet." That was it. Okay, let's meet. Because I didn't really want to continue a conversation on the phone. And the first thing I said to him was, "How long do you want to do this for?" Because I didn't want it to be a tokenistic thing of, I've got this wee project as a student. And true to his word, he said, "Well, I want to get it up and running and I want to see how it goes and grows." So we started with a few groups in the community. We'd invite medical students along to the meeting and lived experience members of the community who had close links with the recovery stuff. And the lived experience community came in their droves. And the medical students came in very small numbers. And we were a bit disheartened at first, thinking we want to get both groups together to share the experience. And people who had an interest in addiction recovery from medical students would come. But we wanted to reach people who wouldn't come, who didn't think they had an interest. So we kept writing to universities. We eventually got in contact with Dr. Shona Anderson, who's a consultant psychiatrist in Dundee University, who came on board with us right away. She's part of our steering group now, it's Humanizing Healthcare. And she came on board, and we were lucky enough to get on a pilot up in Dundee University that's now we're on the curriculum Dundee University.
Wow.
And we wanted more students. So every single student in their studies will meet with somebody with lived experience, and we wanted that across Scotland. So we kept writing to Glasgow University, and we get no response. We think we sent about 13, 14 emails, just persistent, saying we'd like to introduce. We actually laid out, Hugo had come up with this plan, how they could actually fit it into their curriculum, and kept doing it. And then I had a contact with the Scottish Government when I was on Drug Death Task Force, and I included them in the email, and they get back to us pretty quick.
Right.
And we then had a meeting and we discussed it, and now we're on the curriculum for Dundee University. St Andrews University, Aberdeen University, and Glasgow University.
Wow.
So we'll make contact with about 800, 900 students every year, and they'll meet with people with lived experience communities, and they have 5 sets of questions. We do the exact same thing every week, and the research and the stats prove that 99% of the students come along love it.
Yeah.
They get away. I actually had an experience a few weeks ago where I went to the hospital and I had to get blood, and I can't get blood. I've no veins. And I said to the guy, like, you need to get it in there. And he said, oh, I'm a phlebotomist, I can't do that, so I can only take it to the front, blah, blah, blah. But the doctor came in, and he was a FY2 doctor, and he was on Wishaw General, and he said to us, you tell me what it is. And I said to him, what unit did you go to? And he said, Glasgow. I said, did you do a cut? And he done it, Allan. And he started asking questions. He'd been on the Conversation Cafe course.
Oh, yeah.
And he actually said to us that he had learned about asking me where the best place in my body to get a vein was because of that, because he was sitting at tables with all these people who lived the experience community were telling their experience had been a bit negative, and he wanted to make it a bit positive. So that's the knock-on effect for that. And why I get involved with Hugo at that time as well, one of the students at the time left the early sessions after an hour and a half in tears, stating that she'd learnt more about addiction recovery in 1.5 hours than she had in 5 years of studying, because the medical schools don't really teach anybody. And a lot of your doctors in the community as well, who work in their teams, haven't really accessed that sort of stuff. So we had one with all the doctors and prescribers in Glasgow a few weeks ago, which is massive. And I think a lot of them really get a lot from it. One of the doctors we did it a few years ago in the deep end practices, then she had said that she wished she'd been to a Conversation Cafe 20 years ago. So I really understand the value of it. But my whole motivation for getting involved in it was to make sure that it was sustainable. And we've grown it to the point where we've actually employed Zach as a coordinator in the last couple of years, and we've been able to sort of grow that. And I think we've got a few gratitude events, because we don't really want to pay people for coming along. We want people to come along because they really want to be involved in passing that message on to these medical students, and to get contact with other people, develop confidence, self-esteem, various things like that through doing that. And it takes away that sort of barrier of, oh, they're the doctor and I'm somebody from the lived experience community, and be able to share their experience. But I love it. It's probably, it's easy thing to do because I'm so passionate about it, because I really wanted people to come along to your services and experience a real positive impact, be treated with dignity and respect, meet a doctor who's going to listen to them, understand them, and these are the future doctors who are going to be in our communities.
Yeah. And as somebody that's came along on a number of occasions, I've been along at Glasgow Uni, I've been up at 9 Miles, we did it up at 9 Miles as well.
And the video you did?
And we did, I took part in the video for it, but it's certainly one of the kind of newer kind of projects that felt really beneficial, exactly for what you were saying there, when you meet that person who's attended that and he's kind of putting that into his practice. But I was really surprised about the lack of kind of addiction kind of work or studies that trainee medical staff get at uni courses. Is that something that we could push to change, or is it going to have to be through kind of projects like Humanizing Healthcare that they're going to get their information? Because usually your first port of call is to go to a doctor if you've got addiction issue, isn't it?
Yeah.
You know?
That's what we usually get across to the students, is that you'll probably be the first port of call. Sometimes people are reluctant to come into your service because we'd be asking questions like, do you drive?
Yeah.
Do you have children? And they might be a bit scared to mention it, but they'll go to the doctor with the confidentiality and say, look, and we always say to the medical students as well, that they won't always come in and say, I've got a drug problem or an alcohol problem. It might be I feel depressed. Every Monday morning I really can't get up and face the day. And if doctors are a wee bit more savvy to actually ask different questions, they use drugs, various things like that people might open up a wee bit because they're frontline. And even in A&E, then lots of people get in there and hopefully they're treated a wee bit different because they've got a drug problem, that they're not getting treated any different from anybody else. But we all know that stigma is still very much alive in our communities.
And that was a massive thing I've noticed when I've went along to those sessions that he's hold as well. It kind of felt as if it was breaking down those barriers between kind of professionals or would-be professionals and people with addiction issues, you know, and it all came together, and it always felt as if, as much as everybody got something from it, but always felt as if the kind of the trainee doctors walked out there feeling as if they'd learned so much. And it was always great to be part of that, kind of passing on experience, isn't it?
Yeah.
No,
It's massive for
Yeah.
the medical students, as you said. The feedback forms that we get back is, as I said, 99% of people loved it.
Yeah.
And hopefully they'll be able to pass that information on to people. But we talk about them being able to signpost people early. We don't expect the medical professionals to be able to cure us. But if they know about fellowships, they know about recovery communities, they know about services that they can link into, map your area, map the area that you live in or you're working, find out what services are there. And we invite them along to the fellowships, we invite them along to the drop-ins, and some of them come.
Yeah.
And hopefully, for them coming, they hopefully have a wee bit more information when they get into a surgery or into a hospital and they're dealing with somebody. We talk about the navigators who are in the hospital as well, how to identify the pink T-shirts in there. Even just that one service, they think, I've seen them, but I didn't know what they did.
Yeah.
Come to our Ross sessions and find out what you can give to people in the community that will enhance their life, because they might not always want to tell you everything. But if you can say, look, plant that seed, please plant that seed just now, because you're probably first port of call for most people.
Yeah. Amazing project.
Family stuff as well. We get a lot of family, SFAD, FAS who come along as well, because it's about the whole person, the community and the families. And if the family can get a bit of support for themselves, then sometimes they can then enhance that other person's life through getting them involved in some of the services as well. And we get requests from social work, nurses. There's a pharmacy one starting as well, because we do the pharmacies as well. So in fact, they're starting to look at conversation cafes. We've had requests from all over the world for it to do something similar. We did one online to Barcelona students, but we don't have the resources just now to do that. And we in Hugo did that voluntary for a number of years.
Hats off to you, and hopefully it goes from strength to strength over the years, because it really seems to have hit a chord, you know, and it's so beneficial. Okay, a bit push for time. Okay, if MD's listening to the podcast or watching the podcast, Alan, they're in and around the Glasgow area, they've got addiction issues, what would be your advice regarding kind of reaching out for that first bit of help? We spoke there a wee bit about your own service. We spoke about the GP. What kind of advice would you give for somebody who's maybe struggling in isolation, watching this, and things are resonating for them?
I was thinking about that in the sense of how difficult that first step is. And knowing that if I said to you, I really struggle with that, you'd understand. So it's finding other people who would understand that first meeting, that first connection where somebody is massive. I was terrified. And it was the best thing I ever done. But did I do it easily? Not at all. I was terrified to get in and say, I'm Alan, I need help, I'm struggling, because it built up a lifestyle of, I'm fine. Telling everybody I'm fine, when inside I was dying. That the drugs had stopped working years before I stopped using. I used to always tell myself, you need to become a square. I knew that I had to be complete abstinence, not because anybody forced me. I knew that I had to stop using everything, because it didn't matter if I substituted the drugs I was using for medication, for a doctor, various things like that. I still felt that hole. And it wasn't until I reached out and got that bit of hope. That guy encouraged me to go to a meeting, then got to a meeting, meeting other people, open up. But initially, I had to take that first step, and hopefully you're entering rooms, drop-ins, whatever, for lots of other people who see that come through the door. I can see it come through the door. There's a wee bit of literature in there, readings, one of the readings that I like, and it's January 25th in one of the books that I read, and it talks about how coming in, your head's down, you're grey, you don't really make eye contact, and somebody remembers your name, which might sound quite simplistic, but just somebody remembered my name when it went to the next meeting, welcome me in, give me their phone number, take me to the next meeting, take me up to the house, make me something to eat. Just all those connections. But do you know what? After a wee while, the head starts coming up, the eyes start sparkling, as I said earlier on. People start sharing at meetings, maybe at a convention, various things like that. And that's how it works. Because then I'm a wee bit stronger, and then I can say, what about you? Come along here. I'll take you out for something to eat. Don't worry about that just now. We'll get that sorted later. And just that encouragement. It's simple, but it works. For me anyway. And if you can't access any of that stuff because you don't want to get involved in groups, find somebody that you trust. Remember somebody said to us years ago, who would you go to and lie on the couch for a couple of days and break your heart? And I've got people in my life that I could do that. Because life isn't always wonderful, right?
No.
And I've never ever felt that dark ever since. But I've got a few people in my life that I could be honest with and say, look, this is the real me. And all that I'm fine is gone, hopefully. So just reach out, phone somebody, even do it confidentially, find out what services, and go into an online meeting, sit with your camera off to see if you identify.
Yeah.
There's so much, as you said earlier on, technology is that advanced that we can stay in our room. Do you know what I mean? There was during the pandemic, then the fellowships grew with Zoom babies, they called them. People in the house getting it. I need the connection still. I love a live meeting. I love getting in, making tea for somebody, getting a hug, and just giving away what I was given, which just reach out.
Okay, thank you so much, Allan, for coming on the show today. Thank you for sharing your experience. And if anybody is struggling at this time, feel free to kind of message on Abicare's page, and we could maybe help you, signpost you for some support. So thanks again, Allan. Thank you.
Thank you, Edit.